Welcome back, Turd Nerds. Today we are actually going to have a really important conversation about something that a lot of our patients don't realize they have risks for, but that can cause issues that I think a lot of providers miss because they're not even asking the right questions.
I just want to say I really like how we build up to the topic. like people haven't
Every
read the
time.
title. No, we're talking about total suspense here. So what is it?
Okay, so
I'm sure we didn't really mention that.
Dr. Kapadi is going to talk us through GI side effects of non-steroidal anti-inflammatories.
Yes. So, we used to have people on NSAIDs all the time, like 800 milligrams.
Can you define an NSAID? Let's start there.
So I usually, when I'm asking patients, I'm like, are you taking ibuprofen, Advil, Motrin, anything with aspirin? Excedrin migraine, I think, has some aspirin in it. So there's all sorts of names of the other prescription versions too. There's naproxen, Aleve, Etitolac, Diclofenac.
Midol is naproxen.
Midol, yeah.
So is it naproxen or naproxen?
I think there's both.
There's both.
Okay.
Yeah.
Okay.
And it's the same as over-the-counter Aleve. It's just you can do a higher strength prescription. And then there's, there's other heavy-duty ones that we don't those are the main ones that we prescribe.
Oh, and then there's the heavy-duty, like the AS drugs, oh my God, this is going to make me crazy.
Well, there's like Toradol for an injectable version of an NSAID, which we wouldn't prescribe, outpatient, but if they go to the ER or something.
Yeah.
No.
So I think we need most of the regular ones. There's the COX-2 inhibitors, which I have not prescribed in years, but occasionally a patient will be on it, like celecoxib or
right.
They got pulled from the market because
you can still order it, I think.
Oh,
yeah.
Okay.
I think you need like physician approval or some kind of approval.
Yeah, I haven't ordered it in decades, but
Yeah.
I think you can. I'm not saying you
So
should.
they work.
They work
And
so well.
Yeah.
They get people out of pain so effectively.
Yep.
I am scared to take one for like more than one dose.
Same.
Because of my
After this lecture, so I mean the reason we're talking about this is because I went to this really good family medicine conference in September and I texted you guys.
Yes.
After this doctor seems amazing. He's in Idaho, I think, residency director, and he does endoscopy. He's a family medicine doctor, but he does endoscopy.
Oh.
So he does upper and lower GI, and he was doing an endoscopy on someone, and I think it was like a screening one even, or I don't remember. Maybe they had some mild GERD or something. I can't remember what it was for, but he found all these erosions in the GI tract, and he's like, what have you been taking?
Yeah.
And this guy had been on NSAIDs for like a very short period of time.
Oh.
And I don't remember exactly the statistic he said, but it was don't quote me exactly.
Okay.
But from what I remember sending you guys, I think it was something like 40% of people will have erosive changes on scope after a week of NSAIDs.
What?
I have to definitively look that up. I think it was verbal during the conference. I don't have like a statistical backup.
So here's the reality though. I do think that many patients view the NSAID as a supplement, like as a vitamin.
Right.
Like it is
It's over the counter.
It's over the counter. They pop it nonstop.
Yeah.
Like my cousin, when we used to go skiing when we were younger, before he'd go skiing, he'd like take 2 Motrin of vitamin D.
I mean, I've had patients that are like 70 and they had taken NSAIDs daily for like 50 years and had no obvious issues.
And it keeps inflammation down, and like things that keep inflammation down are worth a lot. Like we can tie almost everything we talk about on this podcast to inflammation.
Right.
It works.
Right.
I mean, it was right after this I had all those dental problems, and I'm like looking at the bottle of Advil that I just bought, and I'm like, am I really going to take this? Okay, I'm going to take it for 3 days with an H2 blocker because then I have
so you need to catch us way up.
Okay, so in general, NSAIDs are not without risk, right?
Yeah.
Especially for the GI tract. Obviously, cardiac side effects, renal effects. I don't know the duration of time you have to take an NSAID.
There's a cardiovascular side effect?
Yeah, we typically, I don't like to prescribe it for anyone with heart disease, kidney disease.
Everybody has heart disease. Like any kind of metabolic disease?
But everyone.
Okay. What do we consider a cardiovascular disease? Hyperlipidemia?
No, I think of people with, hypertension, of course, right? Because it can bump their blood pressure.
Yeah.
If they have diagnosed cardiac disease, which I don't know what the percentage is, but it's pretty high in my population.
Cardiomyopathies.
Any cardiac disease.
Any history of AFib?
It depends what it's from. Like, do they also have other cardiac? I don't know of a link between NSAIDs and AFib. Aspirin, they're going to be on if they have AFib now, they're going to be on a DOAC, so they're going to be on a blood thinner anyway, which is another reason you don't want them on an NSAID for the combined bleeding risk.
Yep.
So there's like so many, I feel like when someone wants an NSAID refill and it's not my patient, I do a very thorough
I'm
check
sure you
into
do.
what.
So-
And a half an hour later, I'm like writing them a note to the nurse, like, please let them know they
Do
could.
you give Tylenol?
I mean, it's the lesser of two evils. It doesn't have the organ effects. It
affects
just
the
gives
liver
glutathione. Yeah. And
So just so everybody knows, if you are ever fortunate enough to have Dr. Kapadia be working your case, you know you are getting the most comprehensive
Very
workup.
thorough, the
It's kind
best.
of amazing to pick her brain.
I mean,
it's incredible.
You can only do it for so long. But
I mean,
so far,
and I do think it comes back to your like you have like an insatiable curiosity.
that's true. I do want to know: are they actually like what are they using it for? Like,
And you
what
go
are
down
their
to
comorbidities?
mechanism. It's magical to present cases with
Thanks a lot.
personally.
That's a positive way to look at it, as opposed to neurology.
I benefit from your neuroses. How about that? I
We all
benefit.
do.
Yeah.
We all do. The turd.
Yeah.
So I mean, I asked the other physician colleagues and people who've been doing this for a long time. They're like, "Oh no, I don't give NSAIDs to people
Oh,
that
wow.
are elderly, in general."
What about topical?
Topical is great. I've asked our nephrologist. I said this was a burning question I had for decades, and I finally now I can ask the nephrologist.
Great.
So I sent an e-consult. I said this person has one kidney. Because I wanted to know worst case scenario. This person has severe renal disease. Can I use topical diclofenac?
Great.
And I think this person, it wasn't actual severe renal disease, but they had one kidney. And they said there has been studies and it's generally fine. There's such little systemic absorption. So in general, I tell the person, but I do prescribe topical diclofenac if they have renal
Arthritic pain?
issues.
With arthritic pain?
It's been studied, I believe, for knee arthritis.
Yeah.
I don't think it's been studied for back, but we use it all the time anyway.
Yeah.
It's like it's quite benign as far as
It's interesting
pain
because we try to
medications,
avoid
though.
it in pregnancy because of absorption.
Topical?
Yeah,
That's weird.
that's what I've always heard.
Oh,
I mean, and we don't study pregnant people.
Right,
You know,
right.
so,
yeah.
I do think
like
that's
all
a thing.
our herbal medicine and whatnot.
Yeah, yeah.
But,
I think it is. From what they told me, it has very minimal systemic absorption.
yeah, that would
So
make sense.
Can I just give a very quick plug to the best resource that I've ever discovered for pregnancy and herbal medicine? Do you know what I'm going to say? Do you know what I'm going to say?
I've heard of it, but now I can't remember.
It's so good. So it's put out by Dr. Eric Yarnell, who happens to be one of the formulators of the best naturopathic gastroenterology
Shout
textbook
out.
ever.
He sees a lot of pregnant patients.
He has an entire database that's available to anybody for free
Brilliant.
called BotMed Rocks.
Oh.
Bot Botanical, BOT Med Medicine, BotMed Rocks.
It's for
not
herbs,
that.
it's not for our drugs.
No, it's for herb interactions in pregnancy,
Yeah.
though.
It's brilliant. And
Oh.
lactation, yeah.
That's
And
great.
lactation. He talks about he talks about different parts of the plant, different data.
He's
if
so
there is
smart.
it,
I
he
thought
is
you
so
guys
smart.
basically
You
said
know?
don't. When I've asked you, said basically don't use anything in pregnancy except minerals, maybe some neurotransmitters.
There are a lot of
Minerals,
herbs
water-
that are safe.
Minerals, water soluble. Generally, minerals are safe. Generally,
Vitamins.
water soluble vitamins
Tea
are safe.
versions of not everything. but
Yeah.
some
I
things.
think culinary herbs are generally
Yeah.
safe.
Like
Except
ginger.
well, eucalyptus we don't want to give, but that's
But
not
do I?
culinary.
Yeah. But now what I do is I go to thank you, Dr. Yarnell. We
Yeah.
bow down to you. Our,
There's
our
also a
leader.
great book by Dr. Joel Evans, I believe is his name. I went to a conference he gave in 2002, and he's been lecturing for a long time. He's an OBGYN on the East Coast. I think he's still there, but he has a great book on
Yeah.
the whole,
Herb
it's a whole
interaction.
pregnancy handbook where he does go into some. I
Ooh.
used to send it to my friends who were
pregnant.
It's so worth it. That's
Yeah.
very thoughtful.
Yeah.
Very thoughtful, very sweet. It's just hard because we don't study people who are pregnant. The liability's too high. And we
right,
can't,
and he's an
risk
MD,
it.
so I figured if he says it's okay, there was a handful of things.
I am gonna. The other thing about Dr. Yarnell is, if you guys ever listen to him talk at a conference, he's half dispelling amazing information and half stand-up comedian.
Oh,
It's
that's
very
nice.
entertaining.
Yeah.
But now I have
Is
a
he a
lot.
stand-up comedian?
No, he's
Oh.
like an old
To
naturopath
us,
who's
he
been
is.
doing it. Yeah, he's of our tribe. But now what I'm always doing is I'm always looking at BotMed Rocks. Yeah,
BotMed Rocks.
BotMed Rocks.
Okay, I'll have to remember that.
Okay, so back to
Okay.
NSAIDs.
Yeah.
Now, so I just want to say, thus far, I've heard don't really worry about it for elderly people. Worry about it with cardiovascular disease. Worry about it with kidney disease. I guess what I'm actually worrying about is there's nobody putting the brakes on.
Well, I'm quite careful with prescribing, but yes,
But they don't need your prescription. It's an OTC.
Yeah, I mean, most of my patients want it prescribed because then it's covered, so at least I can talk to them about it,
Okay.
But yes, for most people, it's over the counter.
Yeah.
It probably shouldn't be over the counter compared to
I mean,
how many
the
deaths a
doses
year
you
from
get,
GI
totally.
bleeds from NSAIDs.
Yeah,
It's crazy.
yeah.
or
it's
liver
crazy.
toxicity from acetaminophen.
Yeah, we'd have to look up the statistics. I suspect NSAIDs are worse.
Yeah.
I mean, I do think people, like, I can remember being a child and having, like, one of these older kids that I was hanging out with being like, oh, Advil, you suck on the candy part just long enough, and then you swallow it down.
With no food?
With no food, yeah. I
Oh
mean,
my
I was a
gosh.
child.
That's scary.
That's so horrific.
And
Keep your medicines away from your children. Keep
So, I mean, I think
away.
there are, one of the practitioners I work with has her patients, if they really need to use it every other day for a week at a time. Something like, that has no evidence basis, but it makes sense to me if they're going to use it.
Yeah, except it induces gastritis quickly.
But this was for a week. I don't know, every other day for a week.
Yeah.
Here's
Probably
the thing.
less.
It is one of our best things to stop heavy menstrual bleeding.
Right. Which is so weird.
Wait, what?
I know.
Ibuprofen.
It's the standard of care for dysmenorrhea and menorrhagia.
Menorrhagia, for sure. Especially if folks are traveling or, we don't want to give them...
It's so... Because something with the
prostaglandins. If we don't want to give them coagulants or they can't have access to the herbs that we use for that, it works. It's just like, for the duration of a period, you're inducing gastritis, I guess.
Maybe. Not everybody. Because I'm sure there are plenty of people who take it and don't get gastritis.
Yeah, no, I've had patients who've taken it for 50 years and
but
had an issue.
A lot of my patients have gut stuff, right?
Yeah.
Right.
So I'm like the PCOS people who will bleed out occasionally and the endo folks that
which is weird that it helps with excess bleeding there, but then causes GI bleeding in the different organ system.
I know. It totally works.
Yeah, except for the fact that I can rationalize it with maybe one of the things that it's doing is upregulating the sloughing from the uterus. So it makes the sloughing more productive.
This perfect example are folks with endometriosis because most of them have SIBO. They're in excruciating pain a lot of the time. Ibuprofen is the only over-the-counter readily accessible thing that really works for a lot of people. Yeah. But NSAIDs also induce leaky gut, which is just further worsening your chances of SIBO or healing SIBO. I mean, it's just this cluster of disaster.
Right.
But we can't have people in pain. Yeah. Like that, we can't.
We have to find other things or figure out what's going on. And I feel like when I had my dental issue, Dr. Gurevich was telling me how no one wants to be in pain anymore. And I was like, this sucks. I don't want to be in pain either.
So it is a thing. We were just, before we started recording, we were talking about, I just got back from training at a conference. And he was like, wasn't the flight stressful? I was like, no, because I used to commute with my very young children from the West Coast to the East Coast, every month or two.
Perspective.
Walking up and down the aisle. That was, basically.
It's a perspective.
You could have given me a massage. I would have been less relaxed than I was on that plane.
Yeah, that's true.
Unadulterated, no interruption, work time. Oh, it's like the best.
So basically what we're saying is if you're in pain, try traveling cross country with a toddler.
With a very young, or baby.
Babies are easier. They're
I beg to differ.
Well, I think there's an issue with
Dr. Sanders and toddler face. That's why she doesn't agree with me.
They're monkeys. Lovely. Love her. Monkeys.
I mean, there is the issue with pain if it's chronic that we need to figure out what it's telling us, as opposed to just suppressing it continuously for 50 years, right? But not everyone wants to hear that, and I get it. I mean,
it does take work, and it takes a little bit of money, and it takes time.
But GI bleeds are totally something that I have seen.
Yeah.
It's not that rare.
I also feel like most endoscopies I see have gastritis.
I would absolutely agree with you.
People are inflamed. People are just inflamed, even if they don't have all the issues. We're just walking around inflamed, and we're inflaming it further with NSAIDs.
So basically, after I learned that how it can cause erosions in that short a period of time in a significant number of people, I was trying to figure out what we can do. And around that time, I had a patient who was in the hospital for hematemesis with a very acute GI bleed who had been on 600 of ibuprofen TID for back pain for several months, while we were trying to figure out what to do.
Why do we not give something with the ibuprofen?
This probably should be standard.
I think you're jumping the gun.
Yeah, I feel like that should be standard.
How has it taken us this long?
I don't know why it's not orderable as a combo pill. I feel like it should just be sold.
Oh.
That being said, I feel like we tried.
Or...
I feel like when I was researching this, it briefly was going to come out as a combo pill. It must not have been making money or something. I don't know.
Because keeping people sick in the hospital earns a bunch of money.
I wish that wasn't the case. It makes me feel like, am I a conspiracy theorist now? But it's the case.
I mean, I don't know.
Okay, so what can we do?
We learned in training that giving a PPI with it was helpful.
Yeah.
The problem is I don't like PPIs because of all the other things we've talked about with PPIs increasing the risk of community-acquired pneumonia, long-term absorption, C. diff, all these things. So I don't really want to keep someone on that. So I was trying to figure out what else can I give them. Is there research on H2 blockers? And I had this dental issue that I needed to treat, so I had to figure out what to take myself because I'm like taking this pill, I'm like I'm killing myself. But
quickly, not even slowly.
The dental pain is equally killing me, so I'm going to die either way.
Is there research on H2 blockers?
Yes, so there's research on H2 blockers. So it's somewhat old because, since PPIs came out, I feel like that's generally what's been used. So I looked at a few different things. I looked at one meta-analysis, and they showed basically standard doses of something like famotidine was effective at reducing the risk of duodenal ulcers. But you need a double dose to reduce the risk, or a PPI to reduce the risk of duodenal and gastric ulcers.
So like 20 milligrams twice a day or 10 milligrams twice a day?
20 milligrams twice a day they said was standard, so 40 twice a day was high dose.
So to be
double
clear,
dose.
They're usually labeled as one pill for 24 hours. So you're doing it every 12 hours.
You're doing it every 12 hours at least regular dose. Well, we'll talk about the other studies. For this meta-analysis, at least regular dose, say 20 milligrams BID.
And only while you're on NSAID therapy or after?
This was just studied while they were on it. I'd probably have someone, if it's like a month course, maybe you could do it for a few weeks after, like we do, with probiotics and antibiotics or something like that. Or you could use a PPI. And so that was one of the studies I looked at. And then some of the other ones, this was going back a few decades, because again, PPIs came out in the interim. But they were quoting how famotidine had been shown at that time to prevent erosions in short courses of NSAIDs.
Yeah.
They wanted to figure out if it would be useful for long term, and what they found was high dose famotidine, so this double dose, 40 milligrams BID, did reduce, again, gastric and duodenal ulcers on patients receiving long-term NSAID therapy for arthritis.
So this is interesting because we don't give NSAIDs to people with MCAS if we can avoid it, because it triggers a histamine response. And now adding the NSAIDs, blocking the histamine seems to be a solution.
I think
for gastric erosions and such.
Yeah, but I wonder,
for those patients.
I get your line of thinking. Yeah.
So those were the couple that I looked at. Another one I looked at here. Let's see. This one showed omeprazole was superior to famotidine for GI symptoms and recurrent erosions for those on 24 weeks of aspirin. So this was not ibuprofen.
Okay, here's the reality. A lot of our chronic NSAID users are also on chronic PPIs.
Yeah. That's true, unfortunately.
That is just the world we
live
in.
What do we do? What do we do for their guts if that's like their reality?
If it was me, I'd rather take a high dose famotidine than take an omeprazole.
Yeah. What about DGL?
You could give those things like the slip around DGL, all that. I don't.
So the mucilaginous, the mucilaginous Turds. So I think that I don't know. I am not using anything preventatively when my patients are taking NSAIDs. I am educating them of the risk when they tell me.
Right.
But I'm seeing a lot of gastritis, and for the gastritis, with or without ulcerations, I am using those mucilaginous herbs, and they are very effective. Zinc carnosine, licorice, slippery elm, aloe leaf. No.
Not latex.
Not latex, Inner leaf, aloe, inner leaf. Zinc on its own will help rebuild tissue, but I am seeing efficacy for that, reversing gastritis.
You're just doing it after they finish the NSAID therapy?
I'm doing it after I see a gastritis come back on a endoscopy.
Why wouldn't, when I have to use ibuprofen to stop period bleeding for folks, that there are all these powders on the market that can kind of help that we use to get people off PPIs, help with heartburn, GERD, occasional things like that. I'm using that.
Yeah, I agree with you.
I think that's a good idea.
Short term.
But I feel like the reality of the conversation that we're having is not the short term course of NSAIDs. It's the long term. I use NSAIDs as a vitamin.
Well, I'm thinking about it more because that's why you started this episode. Is short term causes gastric erosion.
Even short term causes even short term.
In 40%, so 60% didn't get it.
That's plenty for me.
That is not. And we don't know that percentage is not validated.
So maybe you put them on famotidine at least, like normal, like 20 milligrams BID. Maybe you don't do the high dose.
Unless they can't tolerate the sedation side effects of the H2 blockers.
Famotidine.
Some people get sedated, I feel like, from any H2s, no?
I don't see that as
famotidine? I've never heard of that.
Really? I feel like I have patients.
I've seen it a couple times, but H1's more.
Okay.
And some more than others.
Yeah, you might be right. Actually, it's probably the
Maybe you forget it. Okay.
Yeah, you're probably right.
Is latex from aloe?
Yeah, that's what makes you poop.
It's
not the latex
Oh,
plant.
there's
no.
There's
stimulant laxative.
Yeah, it's a stimulant. That's what helps.
That's a part of aloe.
That's a part of aloe.
Okay.
Yeah.
When you're looking at aloe supplements,
it's the whole leaf. If you take the whole leaf, you're gonna poop your brains out.
Oh.
Yeah.
So what part do you give for the stomach?
Inner fillet.
Inner fillet.
Is soothing.
And then the outside or the whole leaf for constipation.
Yeah, but it's
it's too much.
Nicer ways to.
Yeah.
Stimulant laxatives you need to be careful with. Tune into our constipation.
You can get
that was such a good
episodes.
episode. That was such a good episode.
But
it's
the
not good
stimulant
to give,
ones can cause bowel dependence.
Yeah.
So if you need to move the things, but think about your prokinetics, think about your osmotics instead.
Right. Because that's a stimulant. Yeah, I was told when I had patients, they'd be on this one product that had aloe leaf in it and senna, and they were taking it every day.
Turkey rhubarb.
It was prescribed by a naturopath. I was surprised.
I mean, I will.
They work short term.
Not only that, but there are some people whose constipation is so
you
recalcitrant.
You need to use something stronger.
I mean, if you're already dependent on them, you're going to need it.
I have patients who are like, we might be on the verge of discussing colectomy because your constipation is so severe.
Yeah.
But can you reverse the dependency, or once it's there, it's there?
I think it depends on what else is going
So
on.
hard. Constipation is really hard.
Okay. We'll try to avoid the stimulant laxatives unless you have to, and then maybe procalcipride can regenerate the nerve.
I've seen people get off of it, but they were like teens, whereas some doctor told them just take your senna all the time.
But then if they're on it and they take it forever, what's the problem with that?
It stops working. And it's irritating to the bowel.
A lot of them stop working.
Yeah, it's like...
And then they need a different or a higher dose, or... I try not to keep people on senna for very long, but I do sometimes give it for a month or two.
Pulse it if you have to.
Not continuously for a month or two?
It's not worth it to me. I would do like 2 weeks on, 2 weeks off if you can.
I have a patient right now who took senna every single day for probably 40 years, and it stopped working. And I have her now, we're cycling through all the pharmaceuticals. She needs 2 to 3 different stimulant laxatives to get some kind of bowel movement. Generally, if she gets it, it's straight up water, but she's on the verge of a colectomy.
What if they're in their 70s, they probably have a 5 to 10 year lifespan? Can I use senna then? Or it could cause a problem within that time span.
Try to figure out why they're constipated.
But these are people in like assisted living and stuff, Rebecca.
But is it Parkinson's? Is it a dementia? Is it nerve damage?
It's usually because they're very sedentary.
Yeah. Is it anorectal dyssynergia? Because that's not going to work for that.
I think it's usually because they're very sedentary.
Yeah.
I mean, yes.
And medication side effects.
Well, so in my thought, if the stool is being retained and it's not moving out, having an osmotic, even something like Miralax.
Yeah, Miralax is usually what we start with, and then I'll add senna if that's not enough.
I mean, I think that's a good call.
Start with or magnesium. I'll put in.
Yeah.
Magnesium and Miralax are the same mechanism of action.
Okay.
Yes, but the difference between magnesium and Miralax is we are all exceptionally magnesium deficient.
Yeah.
Nobody is Miralax deficient.
I took the I took that once, and I felt like I was having neurologic symptoms.
Yeah,
like what kind of neurologic symptoms?
Weird
I felt like I had weird muscle twitches and stuff.
Guys, I have
with like one dose 5 years ago.
I do think we might want to rename this podcast Constipation Talks.
All of the talks.
They always land in constipation.
Well, no, when traveling, it's a big problem for many. Like traveling is a big problem.
You know what a really big hack is for that?
Wait, we should do an episode on that.
Okay.
Traveler's constipation.
Okay. Coming up next.
Sorry, but we should.
All right.
I have a lot of thoughts.
That's fine. What for my patients, for what I have available, I usually use some combination of psyllium, polyethylene glycol, senna colace if I have to.
Yeah.
Senna/colace.
Yeah.
Because they're different mechanisms.
Yep.
Well, they can get it as a combo.
Oh, really?
Yeah. So then I order that, so there's less pills.
Can I just tell you that poor patient is probably going to spend like easily 30 minutes wiping their butt after a bowel movement. It is going to be so damn greasy.
But they're so cut from what?
From the colace.
It makes it greasy?
Oh, yeah. Colace pulls fat.
Oh no! I didn't know that. That's its mechanism as a stool softener.
It's like a lubricant.
So do they become nutrient deficient?
I don't think I've ever seen that. I don't know if I've ever seen data on that.
I mean, people don't stay on that a long time.
Yeah.
Usually.
Okay, so maybe don't do the colace.
Postpartum, that one can be helpful.
We would always use that postpartum.
Yeah, postpartum. I think that's helpful.
Yeah.
Or if they have hemorrhoids, right?
Yeah.
And you want it to be softer.
Slides on it.
Yeah.
Okay, we're gonna have to do another episode.
Okay, so keep going.
All right, so if you are gonna have someone on NSAIDs long term, I would personally think about using an H2 blocker or a PPI. I prefer an H2 blocker if possible, given it has less long-term side effects. You still have to check for B12 deficiency and a few nutrient deficiencies. But
can we just very quickly, I feel like one of the best things that I learned from Dr. Kapadia was the value of running a vitamin B12.
oh yeah, I always run
It's a
B12.
cheap test.
Yeah.
So people get afraid because if we're supplementing with B12, that marker is always going to be high. And then the primary care or the physician gets scared because now it's a flag marker.
Except I've never heard of a side effect from
We don't
elevated
worry
B12.
about
serum B12 levels.
We don't worry about elevated
Right.
B12.
What about MCV being
Different. Let's finish the conversation about B12. We don't worry about B12 deficient. We don't worry about B12 being too high because it's a water soluble molecule and it'll get urinated out.
You can get neurotoxicity from too high.
I've never heard of that. I tried to
research.
research it once, but maybe we should revisit that.
Yeah, we should revisit
Because
that.
B6 definitely, but I haven't heard of. Dr. Wright, I feel like would say I'm probably misquoting again, but I feel like at some point someone said that you can't overdose on B12.
I will say that is something that we should just be running stock in our panels because the main complaint that patients come in with is fatigue and ... and a low serum B12 is exceptionally easy to correct.
Right. Yeah. With oral supplementation.
And
if everyone has gastritis, then they're not absorbing it, so that So and I shoot for, if it's less than 400 or 500, I usually supplement.
My cutoff used to be 400, and now I'm like, I think I want it closer to 600 or 700.
Yeah, at least that's what they said at one of the functional medicine conferences. They said
people feel better. It's like the ferritin cutoffs.
Yeah.
Like we all know people feel better if we just get their
nutrients. And you will definitely have better absorption if you go sublingual than if you go oral. But it's really hard to have a candy in your mouth that you keep under your tongue.
But I did research that, and I feel like you can overcome any absorption issues with a high enough dose, is what they said in the, at least
except pernicious anemia.
I'm not sure if that's accurate.
Because you need the pernicious anemia, the problem is the intrinsic factor.
I feel like they still were giving oral. Anytime someone has pernicious anemia, you're giving shots?
No, I don't even pass go or collect $200. Yes, absolutely.
Okay, we'll have to research that.
Yeah.
I feel like there was a study that said even with those defects, a high enough oral dose can overcome it. But I could be totally wrong.
You know what's crazy about that?
Someone needs to fact check this episode. For sure.
They're also using cyanocobalamin.
So I'm going to do a quick. Okay,
you're going to fact check. Okay, so while you're fact checking,
I have one more thing we need to talk about in NSAIDs, but keep talking.
Well, okay, so while you were fact checking, I think so far my take homes are there's a lot of people taking non-steroidal inflammatories. Yes. It is probably one of the main underlying causes for gastritis. Yep. If you're gonna do it, then you should probably do it with NH2 blocker.
I remember this study exactly.
Okay, what does the study say?
Okay, this is from 2016. We found that, this is one study we found that oral vitamin B12 replacement at 1,000 micrograms daily was adequate to replace B12 in patients with pernicious anemia. We conclude that oral B12 is an effective alternative to B12 IM injections. Patients should be offered this alternative.
Just because of ease of...
I mean, you'll get way better compliance. Yeah. For sure you'll get better compliance.
1,000 sublingual a day.
Not even sublingual. Just oral.
Oral, great.
So anyway.
I see it replenish, but I have questions about the serum B12 versus MCV.
Sure.
Because I don't know.
There's that.
Or methylmalonic acid, which is really the most useful.
Yeah. Only if it's high, though,
Yeah, so I don't know that.
But it tells you about methylmalonic acid tells you how effectively the body is absorbing the B12 that's in the serum.
Yeah.
Because serum is not being absorbed, it's just circulating. Right. Your question is what's happening with absorption.
Is it getting into the cells?
Right.
Yeah.
Okay, so the last thing I want to mention on NSAIDs, there's actually...
We need to fact check ourselves very quickly.
Yeah. I didn't fact check the other ones, but that one, I was like, I want to see... I don't know if I do great on a slums test in general due to the question type of question.
What's a slums test?
It's a cognitive decline test.
I
always tell my husband, I'm like, just if they ever try to give me that test or any cognitive testing, let them know I never could get anywhere from our house except work. I know it is. It's a St. Louis. It's.
We couldn't have rearranged those letters a little different.
There's certain things they ask you in cognitive testing, like if you're getting lost going. I'm like.
Yeah.
Ever since I could drive, I could never get anywhere. This is not a new symptom.
That's because your brain is doing all this other amazing stuff.
That's true,
Rebecca. I can get to work 3 turns. One of the reasons I picked this. Just kidding. I like it other ways, but 3 turns. I don't need Google Maps on. I can get to the grocery store anywhere else. This is how I've been.
Can you get to my clinic from your house?
Facial disorientation disorder. It was on NPR once. I can get to Rebecca's house.
I definitely have that.
One turn.
Okay.
I need to Rebecca's house. I can't get to your house without Google Maps.
Oh, can you get to the clinic?
Yeah, I can walk to your clinic.
Okay.
So if I can walk there, then I'm good. But it's called SDD.
That's a better acronym.
Okay, so get back to gastritis.
Okay, so there's a spectrum of safety with NSAIDs, which I was not aware of. There's a science direct link that if we figure out how to do it, we should probably put it on the episode page.
Okay.
But if you Google, well, we'll figure that out later. So lower risk NSAIDs for potential GI toxicity, ibuprofen is the least toxic.
Okay.
Of the ones we use. Indomethacin is the most toxic of the ones we use.
That makes sense.
Diclofenac and naproxen are in between. So it goes ibuprofen safest, then diclofenac, then naproxen, then indomethacin. So actually, I used to lean towards naproxen sometimes because it was just BID dosing. And it is similar, but according to the study, at least, it's somewhat higher risk.
Aspirin?
Aspirin wasn't on the chart.
Because I think it's a COX-2 inhibitor, right? Aspirin is not an NSAID.
Well, so Tylenol we've got as an option,
Acetaminophen.
an alternative
And-
if we can.
and-
You just
If you're in our Australian, Canadian, or UK audience, you guys call it
Paracetamol.
paracetamol. Yeah.
so are you doing any kind of screening to give that instead? Like
Well, I've asked our transplant hepatologist in the past if I can give acetaminophen
that's a good litmus test.
to my patient
Yeah.
with significant liver disease. I got to fact check this one too because I feel like as long as they were taking an adequate nutrition, they told me it was okay. But they were not.
Wait,
they're
but
not
dose.
actively drinking. The typical 1 gram TID. But let me look at my notes here. Okay. This was a 30-year-old male, history of alcohol abuse and cirrhosis with recent hepatitis, but was not currently drinking.
So acute hepatitis.
Not current,
A history.
recent, but not right this second.
Okay.
Had elevated LFTs at that point, 100 to 200. This was alcohol related. They had been sober for at least a month or two when I was seeing them, and I was advised if they were not drinking alcohol and they were having adequate nutrition, I can prescribe acetaminophen up to 3 grams a day.
3 grams. So that's lower than the healthy person.
But
still.
avoiding NSAIDs with
Yeah.
alcohol,
Right.
with liver disease in general.
I feel like that makes sense. But I also feel like in my patient population, if I'm putting people on Tylenol or it's like around their period or other things
Yeah.
that we're trying to manage pain with, I just go over the top with liver stuff. Like you don't get alcohol. during this time.
Glutathione, milk
Exactly.
thistle.
Exactly.
I would do that if I was taking them. I don't have the ability to order that
It's
right now.
probably over the top, but I'm just like our livers.
I don't
do
think it's
so
over the top.
much.
Yeah.
Yeah.
I'm going for like, am I going to make their cirrhosis worse?
Yep.
You
Yeah.
know?
I mean that's
Yeah.
fair.
Yeah.
Yep.
But this is
Yep.
not optimization.
Yeah.
So I guess the only thing I could give them maybe would be a B complex, which might help with some detox.
I mean, everybody should just get a B complex.
I think.
You'll
Yeah.
feel better.
Yeah.
I never
Even though
felt any different.
I gotta say, I'm also,
take it.
my vitamin B12 was low, my methylmalonic acid was too high. I took 5,000 micrograms of sublingual B12. I didn't
Whoa.
notice any difference.
I
Yeah,
never feel any different,
I
but
am
I
now
take it.
prescribing B12 folate together,
Yeah.
5 milligrams of each.
Wow.
I mean, I always it always made sense to me if you're going to give one B vitamin, just give the complex
Yeah.
because they work
Yeah.
together. I don't know if that's true, but
I mean,
for
I
yes.
see that. I see people
I-
calling
but I'd
it
rather
that.
just give them a B
I
complex.
never noticed any difference in my body.
I don't notice any difference with any vitamins I've ever taken.
Yeah.
B12 makes me really tired, and I have a
Huh,
subset
weird.
of patients. Most of them are histamine. That B12
Huh.
makes them
Are
really
you
tired.
histamine?
Oh, sure. Yeah.
I learned
Why
that if you
not?
take B complex and you feel worse, that it's
Yeah.
a sign of dysbiosis.
I mean,
if you're
I mean,
taking oral.
Again,
No.
I feel like this brings us back to where we started.
I mean, I can
who doesn't
take
have
it.
dysbiosis?
I don't know. I wish we had a better way to.
when
test.
we were in school and we had to like practice the shots on each other, even if it was methylated, I was out for like weeks after that.
Whoa.
Like it
Weeks.
felt like
I've
I
had
was taking
patients that
Benadryl
felt
every
worse,
day.
and I never understood
yeah,
even with the
it was
shot.
insane.
I
wouldn't
think I
touch it.
just.
Do you think
Until-
it's the methylation causing a detox reaction? I feel like they've.
So
had
until
that.
what? Until what?
Even like when I had to take prenatals for being pregnant, I had to take my prenatals at night because they make me so tired.
And the B vitamins didn't keep you up at all.
No,
Any
they
of
make me
them.
really tired.
Hmm.
I mean, B12 makes me
Weird.
tired enough. Yeah. So I don't know, but I've had a couple. I mean, I'm kind of alert for this now because I'm like, what is that about? But I've had a couple histamine like MCAS-C spectrum people where that they've reported the same thing.
Was it
Huh.
methylated B12?
Yeah.
Because I mean,
Which only give.
I did learn that because then that might be giving methyl donors for detox reactions.
Yeah.
So it might be a sign they need to do detox.
I mean,
and maybe
I'm-
use a different form of B12.
Yeah, that's-
Sure. Yeah.
The B12 is also interesting with its forms because adenocobalamin is really interesting for like
Yeah.
mitochondrial support. Hydroxycobalamin, I feel like some patients in injectable form
That's the
actually
standard one, right?
no cyano is
Oh,
the standard.
cyano. Okay.
Yeah.
And I think cyano is I mean, probably not garbage, but
You can inject hydroxy.
Yeah,
and
no.
methyl.
I feel like I have a certain subset of people that are like pernicious anemia people that I just have on injections. And for some reason, for their bodies, and this is like a handful, hydroxycobalamin gives them a much easier, smoother, like B12 injection than methyl.
Yeah.
Methyl seems to spike them and then drop, and it might be a detox thing.
Are you checking their MTHFR status first, or you
Always.
just wing it? Okay.
No, always. I mean, it's such a cheap test right now.
Yeah.
Okay, back to NSAIDs.
We have a lot of tangents on this episode.
Yeah.
I think this is like a gold mine of.
I don't know that it's necessary to test MTHFR, but that's my personal opinion. 30% of the population has it.
So I've heard 40
some theories
to 60.
are that
I've
it's
heard
not
40.
really a mutation. I mean, it's a mutation, but it's not. Like,
So
it's
half the
it's a
population
normal
has
variant.
normal variant.
okay, here is what I'm going to say. I hear what you're saying. I definitely hear what you're saying. And I respectfully disagree, mainly because I feel like if they have a methylation defect, I want to know how aggressively I need to be detoxified.
Oh, for sure. I'm not saying it's something we don't do anything about.
And
It's
the
just-
homocysteine, it's common.
Yeah.
Yeah, I think it does all come back to a homocysteine. If the homocysteine is elevated, we know that is an independent marker.
I think that's a
whole lot
different
of
situation.
things.
Then it would make sense to me to test for it if
Yeah.
their homocysteine is elevated.
Right.
If you're just checking for it in general, because people who have one variant,
Yeah.
it's the whole thing with environmental factors. They're not going to necessarily have issues, and someone with no variants might have
Right.
detox issues. So
Yeah.
I
So
never
I
found
guess
it to be helpful.
let me homocysteine is
I
on my
agree then.
baseline
Yeah,
every
that's
yearly
great.
blood work.
Does it get
and-
covered every time?
It's not an expensive test.
But is it covered, or do
I-
they get surprised?
I can tell you I don't get complaints about it.
Okay, good.
I can't tell
I
you
think that's a
anything
good
else.
one to check
I mean,
regularly.
it's not going to be the vitamin D complaints we get. So
Right.
that's
It's
the
just
one
crazy
that
sometimes.
gets everyone's attention.
And
That makes sense.
and if their homocysteine is elevated, I would always continue
That
to do a
makes sense
methylation
to me.
panel. So so back to NSAIDs.
Okay.
Okay, so risk, ibuprofen's the best, indomethacin's the worst. That
Okay,
makes
none of
perfect
them are
sense to
good.
me. And try to avoid them. If you're going to use them, use an H2 blocker. Maybe use
Or a
some of the
PPI if you want, but not
or a
my
PPI
preference.
if you're on it already.
Yeah.
Maybe continue to use
Some herbs.
some of the herbs that we're doing for gastritis either
Yeah,
way.
nutrients.
But it's basically what I think that the consensus in the Turd Nerds room
Right.
is it should not be an OTC, and yet it is.
And if you can get away with topical diclofenac, that's a great option to try. And I've had patients where they say their knee arthritis is like amazingly better with this stuff.
There's also data on topical ibuprofen.
I think it's a
That's-
version. I think it's
It's both, yeah.
Voltaren is diclofenac gel. I don't know that
Oh.
there's a topical ibuprofen.
I have
it's the same-
patients who
well,
actually grind up their ibuprofen
Oh.
and put it in a gel on their knee.
Well, that would be a
You
good
can get a
hack.
compound.
You
I
can
think
definitely get
it's-
a compound. It's just pricey.
Yeah, because I don't think this is cheap if you have to buy it yourself, but as a prescription, it's covered.
Yeah.
Okay, that was great.
All right.
Yeah.
Yeah.
Thanks, guys.
Yep.
How do we-